McGerrison here. Welcome to TopMedTalk. And today's TopMedTalk is called Montezuma's Revenge. It's a quick refresher on some of the hot topics from ASER 2017, including, of course, the messy topic of bowel prep. A couple of highlights from Professor Monty Mythen and Dr Joff Lacey's live coverage of ASER 2017 for TopMedTalk are about to follow, featuring Dr Julie Thacker, President of the American Society of Enhanced Recovery, and Desiree Chappell, a CRNA in Louisville, Kentucky, board member of EBPOM USA, and, of course, TopMedTalk's lead in America. Have a listen.
TopMedTalk. You know, my favourite international discussion is the bowel prep question. Yes.
I agree.
Bowel prep.
I'm sorry. I think maybe my mic just went out.
So, Julie, people love to talk or hate to talk about the bowel prep. So we used to have this sort of, in the UK, we'd have this vicious cleansing of the bowel. We used to call it Go Lightly, which would have a few days of torrential, of Montezuma's Revenge. And then we discussed that perhaps we should stop doing that. And in some enhanced recovery documents, they say don't do it. But that was very controversial discussions in reaching to a different conclusion, I think, in the consensus document. So can you help us with that one?
We definitively reached a different conclusion, particularly contrary to what I think is in NICE this year. Is that true? For no bowel prep. From the consensus statement, the most important aspect that was brought out was we have managed to figure out some bowel preps that seem to be less hurtful to the patient. Prescribing them and hearing from patients about them, I don't know that's particularly true, but we at least are not bringing patients who are so desperately dehydrated with impressive electrolyte imbalances to the operating room for you to put to sleep now. So if we have a less harmful bowel prep, are we able to institute regular use of that bowel prep to decrease surgical site infection? It's a balance of risks. It's also a balance of patient satisfaction and reporting, which has not been in this discussion thus far. The science for bowel prep has almost exclusively been retrospective, and it has not been carried out in enhanced recovery to any significant numbers. My concern about most of the literature and a lot of the discussion that we had in the group before settling on the publication points was the lack of consistency between knowing what was prescribed and the rest of the care for the patient. I think more realistically what we've seen is as we put everything else in place and as our care overall improves, so we have different broad spectrum IV antibiotics we give at the beginning of the operation. We have different preparation for the patient now. You all do different fluid management intraoperatively. As we put all of these other factors in place, we see infection go down. Now, does the infection go down as much as it would without using a bowel prep? Or vice versa, and that we don't have literature to. And most of the retrospective studies do not report the completion of bowel prep, exactly which antibiotics were used, and what happened to the patient. So about once a week, I'll have a patient who's been prescribed a bowel prep. Yes, that's my sideways way of admitting that I prescribe preoperative bowel preps, who will come in saying, you know, I really couldn't finish this. I couldn't take my preoperative carb drink. I've been vomiting all night. I feel absolutely miserable. And you see that in their physiology when they go to sleep. And I just don't think that benefit I'm getting from trying to reduce their surgical site infection is necessarily justified. But we don't have a prospective study. We certainly don't have a study in enhanced recovery. So I have a feeling this probably will never be answered. So I guess we'll always have something to talk about once a year. But right now, the statement is because we do definitively see decreased surgical site infection in traditional care using a mechanical bowel prep with oral antibiotics preoperatively for colon resections. That was the recommendation made in the paper.
And that's the key with oral antibiotics, because without antibiotics, it's as bad, so to speak, as not using bowel prep at all.
It's actually worse. So the best group for surgical site infection, that's the only outcome that has actually been definitively shown to be improved using a bowel prep, was with mechanical bowel prep and oral antibiotics.
TopMedTalk. Desiree, I understand that the opportunities for opioid avoidance with enhanced recovery, and I think your group's been, a pioneering group in this. Has that been a big factor of it from your perspective down there in Kentucky?
Absolutely. The opioid crisis is hitting here locally, as it is across the U.S., but I believe a couple months ago we had about 50 overdoses in 24-hour period of heroin overdoses. And so it really is something that we as providers, practitioners, are really concerned about what our contribution to the reduction of opioid use here in our state is. And so with our enhanced recovery program, using a multimodal approach to pain management, so things other than narcotics, we are really trying to reduce the amount of narcotics given to the patient, during that perioperative time. We're trying to reduce the amount of narcotics going home with the patient, and hopefully reducing the addictive potential for that patient as well as anyone else that would be exposed to the narcotics that go home with them as well. So we really feel we've had a good reduction of about 60% of narcotic usage within our ERAS program, and about 10% of our patients actually make it through the procedure and their perioperative time here in the hospital without any narcotics at all.
So, Desiree, I'm not sure if you met Dr. Joff Lacey when you were in Washington, D.C. He's an anaesthetist and perioperative physician from London. But he was quite taken by discussions, I think, about the use of alternatives. I don't know, Joff, if you want to pick up on that with Desiree.
One quick question. Prior to the implementation of your ERAS program, would you say then that most of your surgical patients were going home with opioids?
Oh, absolutely. Yeah, they would receive a fair amount intraoperatively, and then postoperatively they would have IV morphine or Dilaudid. They'd have a PCA, that patient-controlled analgesic. And then they go home with up to 120 pills the day they left the facility. And then if they needed repeat or refills of those prescriptions, they could call and get those.
And they could just call and get a
really
top-up.
Yes.
That's quite a phenomenal difference to UK. So that's quite scary in a way. So I can see why it becomes such a problem. Would you say that the patients expect, that's part of the package? You have your surgery, then you get your bag of drugs with opioids in it.
Oh, absolutely. And they expect that they're not going to have any pain afterwards because the narcotics, the opioids are going to take care of all that. So unrealistic expectations are definitely an issue as well.
And Desiree, as I understand, you're using intravenous lidocaine and low-dose ketamine and regular oral meds. Is that part of the new package or just some of those things?
It is. So our protocol looks like this. We implement regional anesthesia where we would do a spinal. If we don't do a spinal or intrathecal bupivacaine and narcotics, we do use a little bit of Dermorph there. If we don't do that, we do a lidocaine infusion for the duration of the procedure intraoperatively. We're using magnesium, ketamine, that kind of NMDA receptor blocker there. We're using NSAIDs, Tylenol, gabapentinoids. We've implemented dexmedetomidine that we run throughout the procedure. So we're really trying to hit all different angles of that pain control, just not the mu receptor.
And your ketamine and lidocaine infusions, is that just intraoperatively, or have you been able to establish a pathway that allows that to go onto the ward or the intensive care unit afterwards?
Right. For us, we are just utilizing it intraoperatively. We're looking into changing different policies that we would be able to continue that on the floor. I know other facilities are very successful with it, and they've been able to implement that into their ERAS regimen. But for us, unfortunately, right now, we can't extend it beyond the intra-op period.
So, Desiree, we're going to have to move on in a second. But overall, how was ASER for you? Everything you hoped for? You pleased with its progress? Is it truly multidisciplinary?
It really is. It's such a unique opportunity, and I feel really personally grateful to participate in something that truly is a collaborative approach to care. I mean, it's bringing everybody to the table. It's a team. It's getting rid of that siloed approach, and we are working together as a group to improve the quality of patient care here in the U.S.
Thank you very much indeed. That's Desiree Chappell, who's a nurse anaesthetist, a CRNA from Louisville, Kentucky, and a board member of the American Society of Enhanced Recovery. TopMedTalk.
Thanks for downloading and listening to TopMedTalk. Don't forget to find us on social media. We're on Twitter, Facebook, Instagram, even got our own YouTube channel. Whichever your favourite social media feed is, we're bound to be there. Find us. Also, subscribe to this podcast so that you never miss an episode. And make sure you go to the TopMedTalk website, topmedtalk.com, and get on board with the email updates. Oh, whilst you're at it as well, I suggest you download our entire back catalogue. We're categorising it at the moment. We're having a little look through it. It may not always be in the form that you currently find it. So if you get your hard drive ready for a full-on download via the website perhaps, or perhaps through your podcatcher. Oh, and if you fancy meeting us, why not go to the website ebpom.org/meetings. Our next big event is EBPOM USA, the Dallas Masters Course, a perioperative care practicum. Have a look for details of that and some of the other meetings coming up across the next year. ebpom.org/meetings.